So it's my great pleasure to introduce this very important webinar hosted by the WHO FCTC Knowledge Hub on public awareness. I would say that prevention science is international, and prevention science has a 50-year long history. So we have therefore to recognize that we are sitting on the shoulders of the giants that precede us. The title of the webinar is "What if the most effective way to implement prevention intervention was to adapt existing intervention to new contexts?" I answer yes to this question with no hesitation. It is the most effective way, but we can discuss it afterwards. We have applied this principle since 2010. We started financing French prevention research in 2005, and that research was very scarce at that time in France. But we quickly understood that this newly funded research would take too long to be finished and then usable in the real world. So we had to go back to the scientific literature and learn more from the giants that precede us. And in the field of tobacco control campaigns, it made me think of two famous pioneers. First of all, Professor Richard Evans from the University of Houston, who pioneered the evaluation of smoking prevention in schools. And he worked on the social influence theory, and he used short films to do the intervention, and that was at the end of the 70s. At the same time, Professor Gary Egger from the University of New South Wales evaluated one of the first media smoking prevention campaigns named Quit for Life in 3 Australian communities. And that work have given an impetus to the very effective tobacco control policies in Australia, and especially the evaluation of media campaigns on smoking prevention. So we have the honor to have 4 speakers that we thank warmly to having accepted to give us a presentation. We have first David Chambers from NCI, who will talk about the implementation science. We have Nandita Murukutla from Vital Strategies, who will talk about anti-tobacco mass media campaigns with a global perspective. And then we have Alice Escon and Benji Horwell from Behavioral Insight team, who started as a part of the Prime Minister David Cameron, and now has an international reach and is an independent research firm or a consulting company. And for the end, we have Emmanuelle Beguineau from the CNCT, and she will show us a case study, an adaptation from Great Britain to France of the ASSIST program, and it's preventing starting of smoking in secondary school. I have to thank very much Justine Avenel, Pauline Bignon, Sophia Di Rosso for organizing this webinar. And I now leave the floor to Justine Avenel, our project leader, who will chair this webinar and just before start with a short presentation of the Knowledge Hub. Thank you for your attention.
Thank you, Pierre, for your kind words and these introductory words. So indeed, you didn't left many suspense about the question of are adapting is something effective, but I hope we'll have some more insights during all the presentations. But a few words about who we are at the Knowledge Hub on public awareness. We are a WHO FCTC Knowledge Hub. So many of Knowledge Hubs exist in the world, but we are the Knowledge Hub on public awareness in relations with Article 12 of the Convention. So we are located in France, near Paris, and our ambition and mandate is to share knowledge and expertise with the parties to the Convention in everything related to education, formation, communication, and public awareness. So to do that, we manage a website that aims at broadcasting knowledge, providing resources. It can be scientific articles, methods, best case, best practices. So we have this website that you can find us on the internet, but know that the website is still in development. So everything is not there yet, but will be in a few months. And also, we bring this knowledge and expertise through technical assistance to the parties. The idea behind this is to assist and support countries, either on a case-by-case basis or, like today, by sharing best practices and bring insights with webinar or conferences. If you feel like you will need any assistance from our hub, from what we do, about the different topics you see on the screen, you can write us an email because you have a practical question or you have more complex interrogations related to the Article 12 of the Convention. So you have our email address on the screen, so please don't hesitate to send us an email and we will see and answer on how we can provide assistance. And now we are going to the really interesting stuff with our speakers, and we will begin with David Chambers, who is Deputy Director for Implementation Science at the National Cancer Institute in the USA. We will talk, we'll say everything about ongoing adaptation. Yes, everything. I see your face. I'm sure you're ready. And thank you so much for being with us today.
Sorry about that. I just had to unmute. Good afternoon, and thank you so much for allowing me to be a part of this really wonderful webinar. Broadly within implementation science, our goal is to make sure that all of the wonderful interventions that have been developed have as good a chance of being able to support people in their efforts to attain maximal health, to prevent illness, and to certainly get the healthcare that they need across the lifespan. So what I would like to do over the next 20 minutes or so is walk you through some general concepts about why we think adaptation of our interventions are so incredibly important. And so it starts with this notion of a more traditional assumption, which is that in order for our interventions to work, they must be delivered with what we term fidelity. And that's fidelity to the original way in which that intervention was developed. So we want to talk a little bit about some of the assumptions that we make as to maximizing fidelity and what happens as a result of that. Talk a little bit about how interventions exist within the contexts in which they're delivered. And then really talk through why adaptation may be argued as an essential part of implementation, but not just that, certainly of sustainment of those interventions over time and of scaling up those interventions so they reach as many people as possible. So that just gives you a broad sense of what I'm quickly going to walk through, and then I will turn it over to the wonderful speakers who are going to give you some great examples of adaptation with regards to specific interventions. So if our starting point is fidelity, it's helpful to think about how we define fidelity in the context of an intervention. So fidelity is generally the extent to which that intervention was delivered as it was planned, as it was originally designed. And so it represents this idea that we can maximize the quality or the integrity of these interventions if we adhere to the ways in which the developers created those interventions, right? So if you look at that second bullet, we talk about fidelity within implementation as the degree to which those programs are implemented as they were originally intended to be by the program developers. And there is certainly evidence that says that the level of fidelity will relate to the effect that that intervention can have on specific health outcomes when it is delivered to a broad population. So the rationale for thinking about fidelity is clear, that we have evidence-based interventions, practices, programs, and if they've been designed in a way that is beneficial, then they should likely be delivered in that way. There's that concern that if our interventions change a lot, they may not have that same benefit that we thought that they were going to have when we saw those clinical trials that established their efficacy or established their effectiveness. And so we have this idea that if there is some appropriate level of fidelity within our interventions that we can maintain, that it's going to increase the likelihood that our interventions will have an impact. Now, depending on the intervention, depending on the circumstance, we have seen wonderful development of fidelity scales. These may be specific to an evidence-based practice and designed so that we have those key components of those interventions that we're determining, are they being delivered? There are other ways in which we measure fidelity. We may be able to directly observe what's going on in practice. We may have clinical notes, depending on the type of intervention, and be able to see within electronic health records whether those interventions are being delivered. We may also be able to look at insurance or payment claims data, different data sources that will give us some indication as what happened when that intervention was supposed to be delivered. Now, our general assumption is that 100% fidelity, the closer we adhere to that original design, will result in the best possible outcome. But I will say that this assumption is often not tested. So for many of our prevention programs, for many of our interventions overall, we don't necessarily know that 100% fidelity to that original design is indeed going to give us the best possible outcome. So we need to think about these really important assumptions as we go forward. So what are some of these assumptions that we have? Well, often we assume that once we've designed our practices, our prevention programs, that they need to remain the same, that they are static. We also often assume that when we know our communities, when we know our various health systems, our prevention systems, that we assume that they're not going to change. We also assume that we're talking about one intervention at a time, one practice at a time. We assume that if we have an evidence-based program, that it's probably going to work the same for everybody, because we often assume that everybody is pretty much the same, even though we know that there's a lot of differences among us. We also make an assumption that if people are not implementing our programs, then it's probably that they're being irrational and they should just do what we would like them to do. Now, I ask you with each of these assumptions, if we were in the same room, I would ask by show of hands, how many of you believe in each of these assumptions? And when I ask this, most of the time, people's hands remain at their side. But if we think about these assumptions in the context of fidelity, what it means is that while we prize fidelity as being incredibly important, we're already realizing that some of the assumptions that would need to be in place to truly maximize fidelity may not be as good as we would like them to. So I want to talk a little bit about the implication of following these assumptions. So one of which is that we put a really important emphasis on the consistency with which we design and then test our interventions. So think about developing a new intervention. We have some evidence base and we create this intervention. Now, over the course of testing this intervention, we usually do some sort of an efficacy trial. If it seems like it's beneficial compared to something else, we do an effectiveness trial. And then assuming that that effectiveness trial shows positive results, we then think about implementation. Now, you'll notice here that the intervention seems to look the same throughout. We are making an assumption that we have designed it as well as possible from the beginning. And is that a good assumption? Now, we also assume that no matter what place we are trying to deliver that intervention, it probably should look the same, as emphasized by looking seemingly being the same intervention, the same look across different sites. Excuse me. So the question is, valuing consistency, what does that potentially lead to in terms of challenges as we go through this process? So the first one is this concept of voltage drop. And the idea is an assumption that we make that our intervention is not going to work as well from when we move, when we complete our efficacy trial and then move into effectiveness and then move into studying dissemination and implementation. And we have good reasons for this. We think that maybe the populations may differ. It may be harder to make sure that everybody gets the same benefit from our interventions over time. The problem that we have is that if we assume that this is going to happen, then we are setting our expectations lower and lower and lower, meaning that the standard for which we think our interventions could be helpful is not as high as we would like it to. So that assumption that we make says that if we're not thinking about adaptation, but we're just thinking about preserving the same intervention, we don't expect that our interventions will be as good as we would like them to be. Similarly, we have this other challenge of what we call program drift, which is another assumption we make that says that over time, as we're delivering an intervention, as we're implementing it, we fully expect that if anybody is changing the way in which they deliver the intervention, that the intervention effect is going to go down. So this idea is that if you change what I designed as an intervention, we are all expecting that that change is going to be bad. Now, what I ask you to consider is whether these assumptions that we make are going to help us in the long run, or do they limit our ability to truly maximize the value of our different interventions? When we think about the relationship between our interventions and the settings or contexts in which they're delivered, the way in which we weigh traditionally the intervention versus the context looks a little something like this. We put all of our emphasis on the intervention, and we assume that the context will sort of work around us. But if we think about what happens in care, in community settings, it usually looks a little something like this. Adaptation ends up being inevitable. And over time, the context is forcing us to think about different ways that we might be able to deliver our intervention. It is changing the intervention around us. This is what happens naturally, but it doesn't necessarily equate with what we at least would like to see happening in that ideal set. Excuse me. So what this sets up is this oppositional relationship between fidelity and adaptation, as emphasized by Darth Vader. This is Darth Vader on the left, Meryl Streep on the right. Darth Vader on the left, you see, looks exactly the same. He's happy, he's sad, he's angry, he's excited, he's disgusted. This is our 100% fidelity intervention, where no matter the circumstances, the actual intervention or what results looks exactly the same. On the right, you could use other people in its place. I happen to think one interesting example would be the actress Meryl Streep, who, as you can see, in all of these different contexts, all of these different performances, looks very different and delivers this particular role, this particular performance, very different. If we can see our way to consider the right side, how we might adapt our interventions, versus the left side, where we are saying there is only one possible solution, we can truly adhere to this idea that there may be variable use of our interventions for different populations, settings, and purposes. And you all know, and we'll see from the examples, that there are many ways in which we are adapting our interventions, and different ways in which we need to adapt our interventions. There may be changes that we need to make so that it is more in keeping with the target audience, the people who we're trying to reach, the way in which these interventions are delivered, cultural adaptations, changes to the service setting, the system that may be needed. And so the idea is that while interventions are going to be adapted, can we do a better job of understanding those adaptations? And might those adaptations actually improve the intervention over time? So I mentioned that concept of program drift, which basically says that we're worried that over time our interventions are not going to do as well. But by just focusing on program drift, we miss this really important opportunity, what we refer to as positive deviance. The idea that over time, we might find better ways to deliver our interventions. So that upper idea is that there is a positive impact to certain types of adaptations. But if we're not allowing for any of these adaptations to occur, then we're ruling out the potential benefits, the improvements that we can make. Now, over time, what we have seen is a lot of progress in being able to systematically capture these different interventions. So Shannon Wiltsey Sturman and colleagues created the frame, which is basically, on this page, a nice schematic for all of the different ways we might be able to learn from the adaptations that are made in practice. And so what you can see, similar to that, to that sort of concentric circles as part of this cylinder, that there are all of these different questions that we can be asking about what are the modifications that we're making, at what level of delivery, in what type of way is this intervention being modified, the nature of that modification. And so what I ask of you is to consider, as you're thinking about delivering different interventions, is there a way that you can more systematically think about how do we need to change these interventions? And then what can we learn by systematically capturing how we changed our interventions and then what happened as a result? Now, if we think longer term, we recognize that evolution occurs in a lot of different places. And I would ask you to think about evolution and ongoing adaptation to our interventions occurring over time. So what you see on the left is a cartoon of the rock group The Beatles. And it shows the Beatles from 1963 to 1970. To me, what this says is that over time, the Beatles, if anyone has followed their music, changed over time. They changed their appearance, but maybe more importantly, they changed the creative output. They changed the music. They learned. They grew. And many people would say that that was a good thing. I would say that's a good thing. So if we assume that prevention and public health is also evolving, should our existing interventions be sustained in the same form that we've created? Can we think differently about the use of these interventions over time and permit for adaptations that are ideally going to make our interventions better? The place that you find this cartoon is this website below, The Evolution of the Beatles' Hair. To me, this is about incorporating adaptation into our thinking about implementation over the long run. So this framework that we pulled together that talks about dynamic sustainability says that consider our interventions are like puzzle pieces. And then the context is like that place where you fit that jigsaw puzzle piece into. Notice as you go around the circle that the puzzle piece, the intervention, is changing shape. And so is the context in which it needs to fit. So instead of saying we need to do everything to preserve this intervention in the same place, what if we're concentrating on maximizing the fit over time and adapting as we go? We think that that ultimately leads to greater public health benefit. And if we're trying to scale things up, if we're trying to scale up our interventions as far and wide, we need to remember that things do change over time. The way that I have listened to music throughout my life or play music has changed, right? We have gone from records to 8-track cassettes to compact discs. We're now in a digital music space, and yet there are many who are still listening to music on vinyl records. The point is that we can't be blind to the different ways in which our interventions and the way in which we use them, the technologies that we have, are changing. And so if we really want to scale up our interventions, we need to be thinking about what are people using, what is being asked for, can our interventions be used depending on available resources, and then what is currently being used upon which we need to think about whether our interventions can fit. Okay, so the broader idea and the aspirational goal is to create a broader system through which we can learn about all of the wonderful ways in which you're thinking about fitting the interventions to the settings in which you work. And can we do a better job of building out the science of adaptation? Because I don't think anyone believes that in all cases, the way in which we first designed an intervention is going to be the best possible endpoint. So what I leave you with, and I'm very happy for people to take my slides as much as you'd like, are a few different recommended readings. And again, I'll click through these very quickly, but this just gives you a sense of some of the really important sources for anything that I've said. And really the credit goes to a lot of these readings for helping me to pull together this idea. So with that, I just want to say thank you. This is my contact information. Delighted to talk to people if you have questions after the fact. And you can see this cat playing guitar. So with that, just want to say thank you, merci, and back to you.
Thank you so much, David. It was a very inspiring, very visual presentation that really helped us, at least helped me, understand the differences between fidelity and adaptation with this Darth Vader and Meryl Streep slide. Capture the essence of the importance of the fit with the jigsaw puzzle. Thank you so much. And the links you made between public health and pop culture, it was very inspiring. So many thanks to you. I'll now leave the floor to Alice Escond and Benji Howell from the Behavioral Insight team. We have a duo of, I think, from the French and English Bureau of the BIT that will try to answer, I'm sure they will answer, the question of do behavioral insights apply across borders? The floor is yours.
Thank you so much. And thank you, David, for that really interesting presentation. I'm very glad you included the source to your Beatles image, because I'll make sure that I'm using that for future presentations for sure. So Alice and I will probably introduce ourselves in just a second, but I guess we were told about the kind of title for this webinar about being, can we, in the context of smoking, take interventions that work in other contexts and apply them in others? And we were thinking about the kind of value that we can provide to this question. We thought we'd stick to what we know, in the sense of looking at what can the behavioral sciences tell us about this question. Can behavioral insights themselves apply across cultures, and what does that look like? So just to give a brief introduction. So my name is Benji Hallwell. I am a senior advisor in our health and wellbeing team in the behavioral insights team. So based mostly in London, currently living in Cornwall. And I cover a lot of our kind of smoking cessation work, looking a lot about work around e-cigarettes, and I guess a lot of concerns around the rise in youth vaping, but also their tool as a smoking cessation aid. And then other parts of our portfolio on smoking cessation. And Alice?
Bonjour à tous. Hello, everyone. I'll speak in English. So I'm also a senior advisor here at the BIT, but the France office. And I head the health and well-being work here in France. We also work across the health spectrum, but notably we've done a few projects with our co-host today, Santé Publique France, including some work on smoking cessation interventions. And we thank them and all the organizers very much for their invitation to today's webinar.
Thanks, Alice. And for those of you who haven't come across us before, so the Behavioral Insights team were also known as the Nudge Unit. So we were set up in 2010 as part of the UK government. And in 2014, we span out to become a private social purpose company. So our mission is all about applying the behavioral sciences to different kind of policy challenges, and essentially using behavioral science to try and improve people's lives. So from our kind of beginnings within the UK government to now, our mission has very much stayed the same in terms of, wanting to have that impact and improve people's lives through what the behavioral science can tell us. So how we're going to structure this, I am going to, I guess, give you the kind of simple answer to this main question about, whether or not behavioral insights can apply effectively across borders. And then Alice is going to give a little bit more nuance to that and complicate the waters slightly. So it's kind of almost like a good cop, bad cop duo between us. So I'll start with, the kind of simple version of this argument. So I think when we're thinking about this question, the very simple answer is that yes, in theory, many effective interventions do apply across borders because they rely on universal features of behavioral insights. So I'm going to work through 3 examples to kind of demonstrate this point. So if we take a slight step back and think about, from a kind of behavioral perspective, why do people smoke, or why do people not quit smoking? Now, there are obviously lots of different answers to this question, not least of which that, nicotine is addictive and that's very hard to give up. But I want to dive into kind of 3 specific features of human behavior that drive smoking apart from this nicotine addiction, which I'm going to argue are kind of common across lots of different borders and contexts. So that's habit formation, social norms or social influences, and what we call the intention action gap. And there are obviously many more I could have picked on, but these are kind of the three that we thought we'd talk through today. So if we start with the first, looking at habit formation. So there are different models of habits, but this is a 4-stage model that I find quite an intuitive way of understanding it. So you can see here the kind of 4 stages of how a habit will typically form. You have your initial cue, a craving, your response, and then reward. So to use the kind of very British example, we can think about this in relation to having a cup of tea in the morning. So there might be an initial cue that triggers that habit. So waking up or going into the kitchen in the morning. There's a craving that's generated from that. So that desire, real deep desire for a cup of tea that's familiar to all Brits. And the kind of natural response to that craving is the making and the drinking of that cup of tea, and the reward, somewhat self-explanatory, but that small hit of caffeine, that warm cup in your hands, the pleasure of drinking a cup of tea. And that's obviously a very kind of British specific example, but the question for us in this context is whether habit formation is something that is common across cultures, and whether this habit formation is something that drives smoking. And the very simple answer to this question, or if we're going to put it simply, is yes, habit formation is universal to human behavior, and yes, it is highly relevant to smoking. So this figure I'm showing here, this is data from a survey of around 17,000 smokers that was conducted across 13 different countries. And it asked them about their habits and in what situations they want to smoke. And you can see from this chart, if you look across all the different countries and the cues that are listed below, you can see that across all of these different countries, even though the specific cues themselves change, and Alice will talk a little bit about that when she complicates the situation further and later in the presentation. But although the cues change, in all these different countries, there are cues that people associate with smoking. So you can see from the answers there, it's things like waking up, eating a meal, being tempted to smoke every time you see people smoking around you, drinking coffee, drinking alcohol. So while that initial cue might vary, the underlying insight remains that habit formation seems to be very relevant across lots of different cultures. And it also is a big driver of why people smoke. If we look at the kind of second example around social norms or social influences, so put simply, this is the insight that people's behavior is affected by what other people do. And this seems kind of uncontroversial, but we want to really tackle this question of, is this something that is universal across different human contexts? And again, not to put too fine a point on it, but yes, it is. And it is something that is highly relevant to smoking. So we saw in that previous graph, the green bars are people who are saying that they're particularly tempted to smoke every time they see people smoking around them. So they are affected by those kind of social influences of other smokers around them. And then here we can see, this is a chart showing people reporting whether or not their closest friends smoke. And what we see is that among smokers in particular, they tend to have more close friends who smoke compared to both ex-smokers and non-smokers. Now, this evidence is correlational, so it's, I don't want to overclaim the kind of causal inferences that we can take from this, but and so there may be loads of other explanations for this association, but I think given the wider literature on people's behavior being affected by others, I think we'd be very surprised if smoking wasn't at least driven by the behavior of people around them, and particularly people that they are close to. And then this final example around the intention action gap. So this is a very broad it's a very broad concept that has a lot of things underlying it or causing it. But the essential insight is that intentions alone are not enough. There is a gap between what we intend to do and what we actually do. And again, the question for us is this something that we see across different cultures, and is it something that applies to smoking? And again, the answer seems to be yes. So this is data from the COVID-19 pandemic, and people were asked, have you considered quitting smoking or quitting nicotine and tobacco products during lockdown? So essentially, do they have the intention of quitting? And then they were also asked, have you actually attempted to do that? So it's very nicely getting at that kind of intention versus the actions. And what we see is that across all of these different countries, and we've looked at data for France as well, and it's very similar. You see there is a gap between what people are intending to do and what they actually do. The only anomaly for this seems to be India, where clearly they have some kind of superpower, willpower, where immediately they want to do something and then they go ahead and do it. And we're not entirely sure why that would be the case in this data, but I think across all the other countries that we see, and indeed France as well, we do find that there is this kind of gap between people's intentions and their actions. So to round off my section here, I guess the takeaway for us is that if we are taking interventions from other contexts, we can do that successfully, so long as they are underpinned by these kind of universal features of human behavior. So interventions that work should make use of that kind of social influence and social norms. So a big part of the reason why indoor smoking bans have been really successful across lots of different cultures is that they make smoking a much less salient thing within social situations. So if you're sending the smokers all outside or to specific smoking areas, you're taking them away from others where other people might be tempted to smoke, and also, making this slightly like dirtier or more disapproved of activity where people are having to go to these slightly dingier, often dingier locations to go and smoke. I think somebody's just come off mute. Okay, that's gone again. And then I guess just link it back to the habit formation. So interventions that are able to disrupt craving, so particular medication that can do that, or are able to substitute that habitual response with some less harmful behavior. So the example here of kind of nicotine gun or potentially e-cigarettes. And then this final point about, if we want to tackle smoking, then it's helpful to help people overcome that gap between their intentions and their actions. So within the UK, we have the month of October is this kind of Stoptober month, and there's a very similar campaign in France called Moi sans tabac. And this is all about, giving a really clear reference point for smokers. This is a month when you need to quit, and providing them with lots of additional support within that month to help them translate their original intentions to quit into an actual action. So that's the kind of very, that's a very straightforward argument about presentation. I'm going to hand over to Alice now, because she's much more capable of talking us through a bit more of the nuance and why the situation is slightly more complex than maybe I've set out.
Thank you so much, Benji. So yes, maybe it would be too good if we stop there. And as we all know, the practice is more complex than the theory. So actually, as David really brilliantly pointed out in his presentation, context matters, not just context, but culture, policy cultures. All of these are factors that matters greatly in influencing the effectiveness and also the likelihood of implementation of an intervention. So as you understand, I'm the bad cop situation here. So I'm going to slightly contradict Benji in that some of the intervention levers that we've seen, the social norms intervention, the intervention that pushes from intention to action, or even the habit substitution interventions, don't necessarily work the same across contexts, because yes, the underlying mechanism seems to be the same, but the specific form an intervention should take has to be adapted to the local and the cultural context. Again, in line with David's presentation, we didn't even coordinate on this. So if we go to the next slide, let me demonstrate this with an example. So the story takes place in China in a textile factory. So there's a litter problem, and researchers wanted to know how to encourage workers in this factory to throw waste in the trash cans instead of on the floor, as they currently were doing. So they tested two interventions. The first one was finding the employees who were doing the bad behavior. So that's like a classic policy intervention. And the second one, a more behavioral one that you could call also a nudge, was to place golden coins on the floor, which is in China a symbol of luck and fortune. And what did we see with the results? Finding failed to make any difference, while golden coins worked. Supposedly because the workers didn't want to put trash next to a golden coin, which carries this strong meaning for them. So I believe that if you try to replicate this in France or in the UK, I'm not entirely sure that this would work because it doesn't have the same significance than in China. Perhaps a symbol of a four-leaf clover in the UK, or maybe a symbol of an expensive cheese in France, something like that might work, who knows? But the point is that the specific nod or incentive for them to work have to be adapted before they can be replicated. And that, of course, has some relevance to smoking. So, for example, an incentive to encourage pregnant women to stop smoking might be a good idea across contexts and across countries, France, UK, or China. But what exactly this incentive should be might vary across culture, directly money or voucher for groceries or for certain activities, etc., etc. So this was an example with incentives, which is a pretty straightforward example of adaptation. Let's look at another example now and come back on habit formation and the graph that Benji presented. So if we were to design an intervention leveraging on habits, we could try to target our interventions when people are most likely to smoke. So identifying their cues to craving to smoke. That could be a good idea regardless of countries, but that specific cues can be different. So if we look in the UK, so this is the green square. So we see that the second situations where people smoke is every time they have an alcoholic drink. So pubs could be a place that intervention targets in the pub, or even better right before entering a pub, for example. Now, if we take another example, for example, in France or even in Greece, we see that the second situation where people want to smoke is when they have a coffee or a tea. So in that case, we'd be targeting probably cafes or just before someone gets to a cafe, for example. So what I've presented here on habit formation also would work with other examples, for example, social norms intervention. So they too can be more or less effective depending on whether you are in a said individualistic culture, basically putting yourself first, or a collectivist culture, putting the group first. And there's been research demonstrating this, for example. And of course, we've been talking a lot about countries, but we all know context is not just geographic, right? So within countries, even if you take two companies in the same country, let's say one where social cohesion is high and one where social cohesion is quite low, your social norm intervention for smoking will likely to have a very different effect. So lastly, we move to the next slide. We wanted to bring you a last point to your attention. So another reason that we shouldn't overlook why effective interventions, whether actually they are behavioral or not behavioral, do not always copy-paste across contexts or countries, is that people who decide what to put in place also have their own priors, values, preferences, and sometimes biases. So one other topic, a bit controversial, but that we wanted to touch on is, for example, the question of vaping and e-cigarettes. And for now, let's just talk about adult population. So the current evidence on using vaping as an intervention for smoking cessation is complex and incomplete by the sheer fact that this phenomenon is quite recent. So we don't have yet the insights to make claims on long-term health effects, for example. But some studies suggest it can be a good tool to help adults stop smoking because of what we mentioned before with the habit substitution. So with that same body of evidence available, some countries are taking different policy decisions. For example, some countries like France or actually US or Australia aren't recommending vaping as a smoking cessation aid. The UK is right now pushing and recommending vaping as a smoking cessation aid for adults. And that's because the major values underlying the decision is either based on precautionary principle, we don't know enough so better be on the safe side, or harm reduction principle. From what we know now, it is an intervention that can reduce harm of smoking, so let's promote it. So clearly, it's an example where we see that evidence is not the only guide, and that's probably not news to any of you here, but good to be reminded of that in the context of policymaking. And secondly, a choice of what a policy or program implementers choose to adopt are influenced by what they have chosen to do in the past. This is what a concept in econ and political science called path dependency, where once you're in a certain policy path, it's harder to deviate from it and that for many reasons. Because of learning effects, so we've invested a lot in previous interventions, we've gained expertise, we've learned from it, and it's now in the future easier to rely back on familiar strategies. So that can be the case, for example, if we have a tradition of using these big communication campaigns to address health problems. We're likely to continue doing this even though there's little proof of effectiveness. Or if we are currently invested in a big program, then we feel like if we were to switch to another way of doing things, that could be a waste of previous investments. That's what we call sunk cost. Or even a third factor, we could be scared of putting up new solutions because we fear the public perception of it and its acceptability in the eyes of the public. So this is what we observe, for example, a lot as a real concern for policymakers, and for good reasons. But sometimes, one, they can be wrong, and actually a policy is actually more accepted than what it is perceived. So it's an example with financial incentives, for example, where there's a bit of a automatism to think that it's not going to be an acceptable measure. But when we look at the data, actually, and even for smoking, we see that it is quite accepted by the public. And two, it can also be the case that public acceptability of a measure sometimes changes as a new solution is deployed. And we've seen in the past many examples of that happening for other policies. So all in all these concepts contribute to resistance to change and a preference for established way of doing things, regardless of effectiveness. So as a conclusion, and to kind of bring our arguments together, we've seen that understanding human behavior is key to designing effective smoking cessation strategies, that many behavioral insights are universal and apply across borders. So in other words, the underlying model of behavior is the same, but that there is a need for significant adaptation to context of any interventions, because as we've seen, context and culture matters in making or breaking a program. And lastly, that good ideas and evidence is not enough. And we must also take into account all the factors that come into play when we or our policy or program implementers decide, or in fact not decide, to adopt a new approach or a new program. And I think that's it for us. Thank you very much.
Thank you so much to the both of you. I had some intuition that the answer you would give to the question you asked at the title would not be even a big yes or a big no. But I love the discrepancy between theory and practices that you embodied with your two presentations. And it responded very well to David Chambers' presentation. So I think it was perfect to maybe shed some different light on this subject. And you provided very specific example to our issue that is related to tobacco. So many thanks. I remind the attendee that you can ask Benji and Alice a question on the chat box, or wait for the end of the webinar to ask them the questions. Now we will give the floor to Nandita Muruktula, who is Vice President for Global Policy and Research, Policy Advocacy and Communication at Vital Strategy. And she will shed some light on a specific kind of adaptation, which is adapting mass media campaigns.
Thank you, and good afternoon, and thank you again to the organizers for having me here today. I will talk about adaptations and the use of international message testing to accelerate tobacco control media campaign implementation globally. A quick introduction to myself and the organization I represent. I'm a behavioral scientist, and at Vital Strategies oversee the global policy and communication and behavioral science research that we do, and I'll describe some of that research today. Vital Strategies, we're a global health organization. We work with governments and civil society organizations in over 73 countries on the most pressing public health problems that include air pollution and health, childhood lead poisoning prevention. We work on several data for health projects, food policy, overdose prevention, and of course, tobacco control. Our tobacco control work is under the Bloomberg Initiative to Reduce Tobacco Use. So a lot of the work I'll describe today is a result of that initiative. The key points in my presentation today will be the following. First, I'll very briefly define what we mean by a tobacco control media campaign, as well as summarize what we know of its effectiveness. But the key takeaway here is that it is still a globally underutilized intervention. Adaptation is an effective strategy for accelerating tobacco control media campaign implementation, and I'll describe some such examples of adaptation in practice. And finally, I'll describe the role of international message testing studies, such as those we conducted as part of the Bloomberg Initiative very early on, to identify the sorts of messages that would lend themselves to adaptation and how they were subsequently adapted for use. So for most tobacco control media campaigns, what do we mean by that? They are a core intervention in FCTC. Tobacco control media campaigns are one of the main policy interventions in the Empower package of WHO. What we mean by a media campaign specifically is a communication activity that lasts at least a 3-week period that utilizes mass media. This could be TV, radio, and today the internet. And it is intended to promote tobacco control, whether it's cessation, preventing initiation, reducing exposure to secondhand smoke, or creating support for Empower policies. This definition, therefore, distinguishes a media campaign from the kind of PR or single-day communication activities that might be implemented around tobacco control. And it is therefore also different from the interpersonal and more targeted community communication interventions that are also important, but different from the population level intervention that's described here as a media campaign. To continue with the definition, a successful media campaign hinges on 2 elements. And it's really important to recognize this because this distinction is a key component of a successful adaptation. The 2 components of a successful media campaign include, foremost, effective messaging. So the messaging is clear, compelling, understood, and fundamentally persuasive, and it resonates with the target audience. The second component to a successful media campaign is strong delivery. So here we're describing the media channels that might be used in a certain context and using those that will reach most people. So the same media may not be prevalent in every country, every context. So picking the right media in every context and picking the right messaging, especially presenting it persuasively in different contexts, together creates a successful media campaign. What we also know from decades of tobacco control media campaign work, all of it steeped in the behavioral sciences, is that for a message to be effective, it's not just about educating and informing, but it's also about tapping into fundamental motivations that get people to change and to act in ways that promote their health. So changes in attitudes, communication messages that start to shift social norms and ultimately tap into motivations are what result in effective messages. And when implemented this way, when implemented with effective messages, implemented at large scale, tobacco control media campaigns are effective at promoting smoking cessation, they prevent initiation, they can shift social norms, and they create policy-friendly environments. And there's substantial evidence at this point from both high, low, and middle-income countries that they are highly cost-effective. As an example here, and this has been peer-reviewed published, a single smokeless tobacco campaign in India, an intense campaign, was found to generate an additional 17 million quit attempts at only about 6 cents per quit attempt. And yet media campaigns are underutilized globally. This is data coming out of the Global Tobacco Control Report of WHO. And what we find, this is the most recent one, is that media campaigns have spottily been implemented, especially at the national level. and with not equal implementation across all the characteristics of an effective media campaign. So the intervention is underutilized, and resource constraints appears to be one of the main reasons for this underutilization. And so here's where adaptation comes in. Adaptation provides a strategy for accelerating media campaign implementation globally. And by adaptation, what we mean is literally the process of taking a media campaign that was developed and found to be effective in one context and reusing it in another context. It's a strategy that can allow low resource settings to implement high quality media campaigns with minimal costs and time. Now, let me give you an example of what I mean by an adaptation of a media campaign before I get into more details of a successful adaptation. So here, and I hope this will work, is the original ad that aired in Australia.
Every cigarette is doing you damage. This is part of an aorta, main artery from the heart. Smoking makes artery walls sticky and collect dangerous fatty deposits. This much was found stuck to the aortal wall of a smoker, age 32. Every cigarette is doing you damage. Call Quitline on 0800 778 77.
Okay. Now this ad was adapted and aired by the government of India. And so here is the adaptation of it.
Every bidi cigarette is doing you damage. This is part of the main blood vessel to the heart. Smoking makes the walls of blood vessels sticky and collect dangerous deposits. This much was found in the blood vessel of a typical smoker, aged 32. Every bidi cigarette is doing you damage.
Okay, so that is an example of adaptation. What you can see is that the core message has remained the same. Even the execution of the ad, a large part of it is the same in both contexts. What has changed is the top and the tail of the ads. The start and the finish have been varied to the context, including that end frame that describes the cessation services available in the two countries. Oops, sorry, I meant to go to the next slide. So now from these adaptation experiences, and there are plenty of these, there have been some key learnings from doing this successfully and not. One core learning, adaptation can save time and money. So as you saw in the previous example, by reusing an existing ad, the government of India, with support from Vital Strategies, was able to save on the cost of producing a new media campaign, producing new material, which is a significant cost saving. So it can be quicker, it can be cheaper, it can be faster to do. But it must be strategically planned. Not every media campaign is appropriate for adaptation. It has to align with the strategic objectives of the proposed communication activities. It must apply the scientific principles that relate to the messaging, the context, the media. So it's only when all of that is carefully considered does adaptation become a viable option. But most of all, it must be tested. Not all media campaigns, and we know this from testing media campaigns in varied contexts, are adaptable. Not all messages transfer well, not all depictions resonate. So making a distinction here between the message and its execution, and formative research and message testing is a key component of an adaptation strategy. So moving on, international message testing provides one such solution. And, I should say here that formative message testing and formative research can be done in every country and every context. But early on, when we were rolling out our tobacco control work across about 15 countries, there was a need to move rapidly. So rather than do studies in one context at a time, we set out to test this question: can we find core elements of messages that work universally across 10 different countries and subpopulations within those countries? What would be those core elements that we can learn from and adapt quickly, and how best then can we help governments in scaling up their tobacco control media campaign strategy. So that was the overarching thinking behind the international message testing studies that we did, all in collaboration with Cancer Council Victoria. 3 publications resulted from this collaboration. I won't get into the details here, except to say that we used highly standardized approaches, mixed qualitative, quantitative methods. We chose ads carefully selected based on inputs from countries as well as from an international panel of experts, and tested them on dimensions of message effectiveness, all of this drawn from behavioral science theory, from message acceptance, perceived effectiveness. We looked at the kinds of emotions that were elicited from the messages, and from this gleaned what messages essentially work across contexts and what do not. In sum, our findings were as follows. There is more in common across countries than not. In fact, in some ways, there's more heterogeneity within countries, within some subpopulations, but a lot in terms of universal behavioral principles that are in fact common, particularly motivators. A few ads emerged as most adaptable and universal, and these were the ones where fear of disease was communicated and was described as the driver of action. So graphic imagery, particularly of diseased human tissue or body parts, disgust provoking simple metaphors, not complicated metaphors, not complicated metaphors of objects that are not familiar in different contexts, but the simple ones like a sponge that's more or less universally found, were remarkably effective in communicating the fear of tobacco use and promoting cessation. Anything that was complex, relied on medical terms, metaphors, was not as effective, and neither were personal testimonials. From the qualitative discussions, we learned that the personal testimonials, these are messages where individuals talk about their own experience with tobacco use and the harms that resulted from that use, less effective because the people and their stories and their lives were less universally relatable. I should just say that this approach to message testing and media campaign implementation is one that we have subsequently used in our road safety and injury prevention work, as well as in food policy. And there's a remarkable replicability even in this approach of doing international message testing to guide media campaigns as a behavioral intervention. So I'll sum it up here in the interest of time to say that media campaigns play a crucial role in tobacco control. We know from decades of experience that they're not only effective, but highly cost-effective interventions at the population level. Adapting media campaigns to different contexts and audiences is a good way to accelerate implementation, but it must be grounded in evidence. International message testing studies are yet another cost-effective way of testing and identifying universal principles of messages that may apply beyond a single context. In the case of tobacco control, we found that graphic imagery, fear of disease, but all of it rendered with executions that are universally understood and known, are highly effective. Subsequent to that, we made all of this material available at the website you see listed here, and it continues to be available for use globally. Thank you.
Many thanks, Nandita. Thanks to your presentation, adaptation looks so easy, but I'm sure there is a lot of work behind what you presented today with all the evaluations you might have carried to have these conclusions. But thank you for making it crystal clear for the audience today. I bear in mind the key learnings you gathered for our future work here and for the Knowledge Hub. And I'm nicely surprised to hear that some of these key learnings are applicable for other issues than tobacco control. So many thanks. I have seen you have some question in the chat box. You can either answer by writing the answer or wait for the Q&A session at the end of the presentation. So we have one last presentation, which is another example of an adaptation that was carried by the CNCT, which is in French, le Conseil National. Oh, okay. I didn't see the presentation that popped up. Le CNCT, which is the Comité National contre le Tabagisme, and Emmanuel will present us, I think, in French. a case study of the experimentation that is called ASSIST. Emmanuel, the floor is yours.
Thank you so much. Thank you for inviting me. And I would like to associate to my intervention as well the people who are mentioned on the slide, Mr. Guignard, Nguyen, Pierre Bisson, and Luc Josran. So as it was said already, the experiment is more practical because it's all about experimentation and adaptation in France for a smoking prevention program called ASSIST. So this program came up in the French context, as you can see on the slide. So despite a recent decline of smoking among young people, it still remains a major problem in France. What we know is that the proven link between early initiation to smoking and smoking in adulthood. And there is a link with the fact that the earlier you start, the harder it is to stop smoking. So it is so important to start at an early stage to really go against smoking. And if young people have an initiation, it should be as late as possible. Another element in this context is important. We know that all the prevention programs are an internal part of the FCTC of the Article 12 in order to reduce such consumption. But actually, there are very few school-based intervention programs that have been assessed. And when you look at such programs which have been assessed, actually, very few were found to be effective. This is why it is so interested to look into the UK assist programs, which have been proven to be efficient. So the assist program, what is it about? First of all, it's a British program which has been developed for the last 20 years by the University of Bristol. And since it has been disseminated by a subsidiary, which was called Decipher Impact, now it's called Evidence to Impact, in other cities in the UK and in other countries. And there is a license which is linked to that, a 3-year license, including training of trainers and a monitoring of the protocol implementation. Such program has been evaluated as being cost-effective in the UK, both when it comes to the prevalence and later the onset of smoking among smokers. And I want to refer you to the publication that was made about the evaluation of the program. What are the features of this program? It's in the school environment, but outside the context of the classroom in the strict sense. This program targets young people who are in year 8 in the UK, age 12-13. It's about a peer prevention. The program is based on interventions by specially trained students nominated by their peers. And these children, called ambassadors, have been trained. So it's inspired by the theory of the diffusion of innovation. On this slide, you have the various stages of the intervention with, first of all, the first stage is the appointment of the ambassadors by their peers. So therefore, we get together the children. They do not know at all why they are gathered, and we ask them to fill up a small survey or questionnaire. And you've got the questions on the slide on the left. We ask them, which year 8 pupils do you respect the most? Which year pupils are strong in sport or another group activity, such as theater or music as well? Which year 8 children or pupils do you admire? And out of this survey, we retain 18% of the students. That's the first stage, 18%. Second stage, we meet children who have been designated, and then we leave the secrecy. We tell them, oh, this is about this program. We explain the program. And then what's important is to get the consent. We need both the parental consent and the child consent. Of course, it's important for the parents to agree to this program. The objective is to get at least 15% the target for ambassadors, to have ambassadors. As now, once we have recruited them, we are going to train them for 2 days in a different framework outside the school. It's outside the school, and these 4 days are done in such a way. First day, training on smoking. This training is around game as well, but there is a lot of knowledge component, there's a lot of information and data on smoking. And this idea is to make it legitimate so that the children would appropriate themselves to some principles, you know. And on the second day, it's a training where we lead the children to actually put into practice the knowledge they heard. We had them to have psychosocial skills, basically, more about communication. At the end of this training, what do we ask the children? That within their daily life, they should have conversation with their peers, or they would talk about smoking as a prevention. It's not to identify smokers and this incite them to stop smoking. No, it's more about prevention, talking about smoking, all the components on the in the daily life. Talk about tobacco. So this is their mission. And we don't leave them any follow-up, of course. There are 4 sessions which are scheduled afterward, which will be within the college environment. And we will meet them again to see if they had come across any challenges. We will remotivate the children, these ambassadors, if we feel that maybe they have some difficulties, and we bring them more information. There is a follow-up. And therefore, the whole schedule should not go over 14 weeks. At the end of this schedule, a certificate is delivered to them. So the framing is very strictly settled through a manual, a book. And the idea is to try it in France to see, to assess the feasibility and the acceptability of this program in France, which is a different context than the English context. So we thought, is it possible to have it in a French-speaking context? Are the students in France receptive? What about the training, the methods? Do we need to adapt it? And the colleges as well, would they be ready? Would they be ready to accept it in the French school context? That was the number 1. And if number 2, it's feasible, is it relevant to deploy it? And under what conditions? Number 3, can it be strengthened? To carry out this experimentation, we gathered various partners. First, the French Public Health Agency and the National Committee Against Tobacco, which is a government organization that Justin talked about. We talked about the university. We worked as well with the University of Versailles-Saint-Quentin with the support of the Ministry of Education for the logistic to identify the establishments or the facilities. The manual was translated and some adaptations were made throughout the years, actually, with this experimentation. When it comes to the training of trainers, some changes were made, and for the ambassadors, and for the manual as well. Not only, oh, let's give the you know, not only to take the French legislation, for example, but there were some adaptations because, for example, there is a much more prevalence of nicotine in the French society than in the British society. So we had to adopt more elements or to adjust some things when it comes to this intervention in France. Something else which is really important for the adaptation was that what about the parents' intervention? In the UK, the parents' participation was quite limited, and quite small, but that was out of question in France that, parents would allow their children to go away for 2 days for training. So we needed to integrate that dimension of secrecy, remember, that was important, but as well to give a lot of information to the parents who were very enlightened, about the program. We had meetings with the parents, etc. So in any case, the active ingredients were preserved. First, it was for 12, 13-year-old children, for the protocol, which was structured, the duration, the peer selection method, and lastly, training by external speakers. It shouldn't be any teachers, okay, from that specific college. So in that slide, I tried to show the role of each partner. And of course, we associated the UK because they trained us, the British trained us, and they checked some of this program. And you can see the intervention of the French government and the follow-up, etc. The assessment of the experimentation now, it was between 2016 and 2019. And such experiments included various modalities. First, in the deployment, first of all, we had a gradual increment of the colleges. We went from 4 colleges in the first to 12 and then 19 in the year 3. It was in various French regions, and the secondary schools, of course, were important. They were designated by the French government. We had schools from big cities, from small towns, or in rural zones, or in elite colleges and in unprivileged zones as well. First, we had an evaluation of the program when it comes to the implementation compliance. What about the fidelity, as we said earlier? It was very important. So the British came on site, they came to France. There was monitoring as well when it comes to the implementation. And there was 2 evidence to impact visits during the ambassador training as well and the self-questionnaire. There were 2 questionnaires completed by the ambassadors at the end of the training and at the end of the program, actually, where we could gather and collect the perceptions of the training and the follow-up sessions. How was it? Within the missions, how many conversations the ambassadors had. And lastly, we had a qualitative evaluation based on semi-directive interviews with student ambassadors and other students and teachers, parents, trainers, and educational staff in the school. So on the basis of such experience, which include more than 4,000 pupils and more than 700 ambassadors, we concluded that among the ambassadors, we had a lot of different profiles. Some ambassadors were selected because they were very, very good academically, and the children admired the ambassadors. As well, there were other profiles, such as rebellious children, those who were strong-headed, and they had academic difficulties, but they were admired as well. And then other profiles who were more introverted children, and they were very surprised that they've been selected by their peers, and they never imagined they would have been selected. What came out of this assessment in year 3 was that 85% of the children nominated accepted to be recruited as well. These ambassadors overall carried out the mission. They had these conversations. That's good. Moreover, in most cases, they didn't come across many difficulties, and in any case, they recommended the program to their peers. Such training was interested as well for the ambassadors because they gathered some knowledge, and the ambassadors were very proud that they were selected by their peers. And we found this pride as well among the parents, especially parents of the strong-headed children, and these parents were very happy that their kids had been selected. Some parents found the program interesting, but there were some reservations from parents of privileged children because some children missed the curriculum and the parents were a little bit worried about that. So this is the only reservation. Then there was a need to be informed. That was very important for the French parents. It was different from in the UK. So when it comes to the college leaders, some were a little bit fearful about this type of nomination by children, but however, within the colleges, they liked that. The teachers said that it was good about knowledge and skill, this program, and it was very important for them. They noted as well very positive change when it comes to concentration as well. Some children were, concentrating more. Sometimes they say it was difficult to include the schedule in a very loaded planning as well. And as well, they said that there was a prevention program with a strong education dimension, but the children had fun, so that was really good. For strength, therefore, the principle of the intervention was well accepted by the teenagers and the educational community. The level was good. At the time of intervention for year 8 children, the principle of peer prevention and nomination per pupil template was a strong point. The information nature of the interactions requested was good. It was quite flexible. They liked that informal nature. The right duration, not too long or not too short, because it was important about efficacy. And lastly, they had a substantial education content. What were the limitations? Well, it's a little bit the same as in other interventions. The implementation remains highly person dependent when it comes to facilitators, college contact, etc. A heavy logistical burden and organizational constraints, that are not always adapted to the French schools. And sometimes it was an asset, of course, because interventions could not take place in colleges. We had to find other locations. That was costly. But sometimes we had a connection with the councils, the local council, and to talk about other things, about tobacco as well. So that's really good. Sometimes it's an open door to have communication with, other organizations than colleges. Of course, there is a significant cost. The license is costly, and the implementation, the monitoring, and the application are costly. So at the end of this experimentation, we gave some recommendations on content. When it comes to content, we need to take better account of the way young people communicate today. Social networks should be integrated, but very well monitored. We need to reinforce the content of training for trainers and ambassadors on the subject of tobacco. Some points were a little bit weak, and therefore we need to enrich the follow-up sessions, even to adapt the follow-up sessions, and to strengthen when it comes to improve the training for those involved in managing difficult behavior. On the positioning of the intervention, we wanted to promote establishment to be planned through communication campaigns in the local press, for example, and to include the program in the school education project that was made as well throughout the experimentation. For example, the year 8 children were very proud to present in front of all the children, all the students. And sometimes, it's a tricky moment when children begin to start smoking the year 10 children begin to start smoking. So the year 8 students were very proud to present this. It was important to integrate as well the project within the community. As a conclusion, there are no cultural barriers to implement the program. No cultural obstacles. It was a relevant program, very well structured, easy to follow, and scientifically evaluated. And of course, it requires adaptations and reinforcement of content, and it deserves to be more closely integrated in the school educational project. There are some major challenges. So how to deploy it, for example, how to actually have a training that would give resources and structure, and we needed to assess the effects. So in order to finish, I just want to show you a few pictures of the program. Here you can see, for example, about the ingredients of tobacco. Without telling them, we move on to a cooking activity. They thought we were making a cake, baking a cake. But we started to add sweet, sugar, honey, and then we put some detergents. We told them these are the tobacco components, and that was quite interesting for them.
Something that could be very attractive. And regarding the toxic products, otherwise regarding the items that were given to them, there was an appropriation phase in order to have argument presented during the exchanges. They had different modalities that were incorporated, and we insisted on the fact that they were legitimate because they had that knowledge, but at the same time they were nominated by their peers. They had specific qualities, and what was at stake was to remind them about their qualities, and also we displayed them these qualities, and they had their own qualities, and they the other pupils had similar qualities, complementary qualities. So here you can see role plays that were done on the second day, and they were moving a lot. The game was important within the groups. Here, in order to finish, to show you, it's a follow-up session where we can find more the normal schooling framework. We were not too strict in terms of discipline, and at the same time we were supporting them for the follow-up sessions. And then you can see these little notebooks where they used to write everything in their journals. And we started from these documents each time when we were doing some follow-up session. We used the little journals. A few examples of publications that were disseminated in the press media, mass media, for the school to be recognized locally as well. Thank you very much. Thank you very much, Emmanuel. It puts something very tangible about the various notions that we were able to see during all the presentation regarding the active ingredients at the intervention and on the items that needed to be adapted during the experimentation in order to have a better fitting within the context, as you've done it in France. Thank you so much for having been in depth in details for the experimentation that were done. I thought it was very interesting because I had several papers on the experimentations, on the evaluations, and to hear the presentation, to see the pictures of what you've done that makes it very tangible, concrete. So I've rediscovered ACIS. Thank you so much for it.
All speakers respected the given time for their presentation, and it's rare enough to mention it. So thank you very much. And now this is the Q&A session. So I have seen that many questions were asked in the and answered in the chat box. So thank you to David and Nandita for having already answered some questions. For the audience, don't hesitate to unmute yourself and ask a question, or to write it down on the chat box, and we'll ask the speakers to answer the question. Because I'm sure the audience is very shy, I'll ask the first question. I get the same question as Guillemette, who asked Nandita how the copyrights were dealt when adapting a media campaign. And this is a question that I often ask myself. So can I ask a complement question to the one Guillemette already asked? So how did you manage exactly, like did the country wanted to adapt an existing campaign, reached to, for example, the Public Health Agency, and ask them, can you give us the contact details so we can pay for extending the copyrights? Is that the way it worked?
It was actually us. It was actually
part
us
of the initiative,
as
and
part
in
of
our
the
role,
initiative
and
providing
in our
technical
role,
support,
providing technical support
to country governments that reached out to agencies. Often we were collaborating with, a media campaign and communication officers in those countries. So we worked with them, and essentially, for the most part, unless it's, advertising agencies or record labels, they're in it for the public good. And so we have generally had good experience, and others, other content has generally also been made freely available. So it was a process we undertook on behalf of governments and sought those licenses and permissions. But I should say message testing in the countries was an absolutely essential part of governments feeling any confidence in using those materials even before we were able to negotiate those licenses.
Okay, thank you. There is a new question in the chat box.
It is planned to deploy more and more the ACIS program. In fact, I believe that Pierre is going to be able to intervene. One of the difficulty that we had with the ACIS program, it was linked with an existing license, which is quite important financially speaking. And then, like you've said it before, during the experimentation from 2016 to 19, we had the COVID crisis. I believe the COVID crisis, in terms of deployment of initiatives, was a big damper. It had some consequences on the difficulty to develop the program in the crisis, but at the moment it is not currently being deployed beyond the experimental stage in France. Thank you. Another question from Ben. Are there other programs for the prevention of alcohol risk? I haven't got any idea if someone has a reply for that, because we were talking about tobacco first. But if someone can say about alcohol dependency, but we do not know to whom the question is for. No reply. But in order to reply to this question, it goes back to the Laetitia questions, namely the register that can exist. Maybe it's an item in the reply for together the intervention that were done in other countries. It's always very interesting to refer to registry level that existed before. And in order to be able to filter the focus points we want to choose, and these different registers can show you in advance whether it's going to be promising or not. They can give you a few indicative tools in order to be able to see if one intervention on the prevention of alcohol dependency exists. I'm sure they do exist. Another question from Jean-Loup Dureau. For the prevention in the college, what do we know exactly for the future? These people are above 17 years of age. Are they more smokers? I believe here we need to look at the publications, the one I'm talking about from where the reference come from, because the program was evaluated, appraised in the UK in terms of efficiency. And what appeared here is compared to the children who benefit from the intervention, there was a difference regarding the prevalence for the youngsters who started to smoke. They started later, but the appraisal was not done in France. What was done in France is to see the effectiveness of the program. And it's true that we wanted at the time to have quite a few exchanges because in the future we wanted to know what was going to become of the children who benefited from these interventions. It was something that was very efficiently done in the UK previously. Thank you, Emmanuel. There is another person who added a reply of what we said before regarding Luc Lebon from Unisanté, he says, there exists equally a program of school prevention Unplug. It aims at the development of psychosocial competencies and the prevention of addiction. Unless mistaken, it was evaluated with 7 European countries since 2004 for 2014 in France for the 11 to 14 years old. Are there any other questions? Otherwise, in the questions that were written, are there any people who wish to add something, the people who made presentation? Do they wish to add something to that? And if there aren't any other questions, we're going to conclude this webinar. And in order to do so, I'm going to come back to the question that we had in the title in the webinar, the adaptation of the interventions. Is it what is the most efficient in order to implement further interventions? I believe we cannot say yes or no, but the tendency would be towards the yes, because yes, but only yes if it's done attentively with the learning, with advice that were given by the different presenters. But from what I understood from the David Chambers, Benji Howell, Alice Abdullah, and all the other people that I thank very much, all the people who presented the presentation, there's not magical formula. There are different items in the way of doing it, in the methodology, but it needs to fit to the context. And it can be the cultural context, it can be the political context with the various policies that's set in place, and it can be another item which is key in the adaptation, which is the appraisal, the evaluation before and after. In order to do it properly, we've seen different appraisals, different evaluation there. We had a few precise items with the campaigns of communication or the ASSIS program. So thank you very much for all the advice that you have given us. And in order to finish all of it, what we've said before, in order to come back on the different registers, because effectively, in order to adapt an intervention, you need to know other previously made intervention in other countries. And it is obvious. But the question appeared as well in the chat, so I'm come back on that to finish the loop. But there are several registers, and registries, and I invite you to consult these registers and registries on the preventions and awareness for the public. And we are trying at the moment to set up catalogs to set up. We use the registers and registries in order to make further interventions against tobacco. And you can already go onto them. There is a small part of the catalog that is in French at the moment, but don't worry, we're going to translate it into English for you regarding all the various interventions that were done for the young people. And we find again the ASSIST program, of course. And I hope that we are going to be able to carry on these catalogs and to translate it in English, of course. And of course, we're going to make it bigger, this catalog, with other interventions that are going to be added to our catalog. And again, I would like to thank everybody so much and all the people who participated, who did presentation. I hope it was full of inspiration for you like it was for me. I've learned quite a few things, and we hope to find you again for the next webinars that we'll organize by us, probably in 2024. Have a nice remainder of the day everywhere from where you are in the world. And a big thank you to everybody. Bye-bye.